Welcome to the Narrative-Based Medicine Lab Talks series. Today, we're joined by Health Humanities Theme Lead at the Temerty Faculty of Medicine, Dr. Sarah Kim. Sarah, welcome.
Hello. Thank you for having me.
It's very nice to have you here. We're very much looking forward to the conversation with you. I'm Damien Tonopolsky, the Creative Lead at the Narrative-Based Medicine Lab. I'm joined by Karen Gold,
Curriculum Lead at the lab.
Let's begin with a general introduction to you, Sarah. If you could tell us a little bit about yourself and your career in healthcare to date, and maybe what drew you towards your own specialty.
Well, it was a long, tortuous path, and I think where I'd probably begin is arriving. I guess where, for the purposes of this, we will start. Medical school. I went to McMaster. I wasn't a typical med keener. That was a rather late decision that I decided to apply, and part of it was when I arrived. Actually, this is a good memory. I remember finishing high school. I was very science and maths focused, and when I arrived to McGill University, is where I chose to go. I opened the syllabus and I couldn't identify even half of the topics that the university offered. And it was a moment of sitting back and saying, why do I not even know what, for example, anthropology is? Why do I not? And so I left the Faculty of Science, and I don't even remember if I finished the first semester or not. And I asked to be transferred into the Faculty of Arts. And that point, I don't even remember. Oh, I remember now. I asked to be switched into linguistics and anthropology as a double major, and started to take courses throughout anything. But then I found that too limiting. So after my first year, I felt it was still too narrow. And over the summer, I was flipping through the syllabus and noticed they had a minor in what they called cognitive science. And under that, they listed courses that fell in sciences, so like computer science and some of the other things, but it also crossed over to philosophy and psychology. And I met with the dean of the Faculty of Arts and asked if I could do it as a major. And what she said was, if you can write a proposal and craft it according to these guidelines, we'll meet again and we'll see. And so that's what I did. And then I met with her, and she said, that's fine. You'll have to do it as an honors major, which means you have to do more courses. And I think partly naively agreed to it because you don't know what that actually means. But that's what I ended up doing. I ended up doing that cognitive science major, and was able actually to add even more courses. So I add a lot of the arts and humanities categories that were lacking. And eventually they did make it into an official major. Years later, I happened to be flipping through, which I thought was a lot of fun. And after doing that, you arrive in your third, fourth year, and you're asking these big questions like, what do I do next? And in reflecting on what I did sort of in my volunteer time, like my extracurricular, I had a lot of interest in health and humanities, and my academic record was good enough to apply to medical school. So it was something, in Asian, like Korean families, they always dream of having a child go into medicine. And so I did apply. Having said that, I applied with hesitation, not being sure if it would be an environment that I want to study in. And that's why I actually only applied to McMaster. I didn't actually apply to any of the other medicals because I wanted one where we would do discussion and not just rote memorization. And I got in, which was interesting as well. Like that, going through medical school, I also took a research year because I wanted a pause. A lot of it ties into, I think, what we'll talk about later in terms of me noticing things about the relationship of medicine and the body that I found uncomfortable. In particular, how in medicine we process bodies we don't actually treat people. And that's not how we're trained. And that's how the structure of the system is. It's more efficient, but it does leave, I think, on both parts, feeling like there's something missing. And people will describe it as a lack of bedside manner. They'll describe it as feeling like they're just a number. But then also on the practitioner side, we also feel, in a sense, dispensable to the system. So those thoughts, I did spend a year thinking about and researching the history. I did a research year in the history of medicine, and then returned and went through and plowed through. Decided that I found everything about medicine interesting. So I actually loved the scientific aspects. I loved the technical components. I actually loved almost every rotation, and I thought, oh, well, it looks like I can't really narrow to anything. I did think about psychiatry, anesthesia as other like smaller branches of technicality, but I applied to family medicine, and it was a good fit. And then from there, I was still, again, more interested in the physical body, and I subspecialized in sports medicine for that reason. And during, I had a great career, actually, in sports medicine. I got to be one of the physicians for Canada Basketball. I traveled internationally with Canada Basketball. I was their chief medical officer towards the latter half of the decade that I worked with them, which was fascinating. Again, just observing bodies in different environments and in different countries, and how, and that's always a really eye-opening experience, is observing other places where you think, your norm is not the norm. And I've always loved that. And then through sports medicine, you see a lot of patients that have chronic injury or chronic pain. And I felt I had a skill gap in being able to actually meet the needs of these patients fully, in that a good portion of it is, especially in chronic pain, is how do you cope with that? And what are people's pain experiences like? So I started to do a lot more training in counseling, in particular around trauma, because any injury is a traumatic event, no matter really how minor it is. Some people resolve quickly and then the trauma doesn't remain. It can, depending on the circumstances, but things that are lingering, where people's control is taken away from them, those are traumatic things. And so I spent the next number of years training in more counseling skills and psychotherapy skills, and in a lot of the theories around trauma. And that began to lead towards the integration of some of these arts-based things. Because what's interesting about trauma is a lot of people can't voice their distress, but if you ask them to draw a picture or just to free write and you take away the verbal, another part of them manifests itself and can often surprise them. And it's because it's processed through a different area of the brain, if we want to get into the neuroscience of it. And it allows access in a different way. And I think that was when really some of this integration of the arts in my practice began. And, pandemic times came. I really found virtual care stressful. And so I really shifted away from the sports medicine practice and started to focus a lot more on the psychotherapy, but then becoming much more curious about using art as a tool in medicine. Partly it was, becoming also a personal development tool, professional renewal tool, but then also a vehicle for care. And when this job announcement came, a number of colleagues sent it to me. And I looked at it and I think I'm underqualified for this, but I'm going to apply anyway. Mostly because I was never, as an academic researcher, I can do the work, but it's not where my passion per se lies. I'm much more interested in the research where you spend a lot of time in the body, which is, what informs the dance practice that I've cultivated over a decade now, and being a part of a professional dance artist community. And it took me a long time to arrive there, the difference between dance as performance and dance as research and process. So those are different kinds of worlds that I'm still currently experimenting with. The performance in some ways is the same kind of performance you do when you present a research paper. It's, again, a different medium. It's just a different way of arriving in a certain, if you want to describe it in that sense. But I think that is a very long-winded way to arrive at how.
Well, I'm so struck by how so early in your career or pre-training in medicine, you were so drawn to what we might call interdisciplinary practice, study as a way of not limiting yourself to anything and drawing on arts and humanities and science and bringing them together, and how much that parallels the work that, as you said, we do in health humanities, narrative-based medicine, arts-based research. That seemed to be a thread that's followed you all the way along, even though you may not have known it would sort of culminate in what it looks like today.
Yeah. My thoughts on that is, I think I was always a child that would question things, and maybe not necessarily so overtly, because culturally you can't do that. It's the penalty for asking questions can be heavy, but I started to learn how to ask it in a way that's more gentle or indirect, and really being driven through curiosity of structures. The structures we take for granted sometimes as being the only way or the truth, versus this is a way. This is my way of knowing, but there are so many other ways of knowing, and then which ones have greater value in which particular societies and why, and the different purposes. But then I've always been, when things get overly rigid, from a Buddhist philosophy kind of thing, it's you always want to be that gentle willow or sapling that moves, or you want to be like water, or you move according to what things are meant. But if you're rigid, that's when things break apart. And there was, I think, probably some Buddhist influence through the cultural upbringing. I was raised both Catholic and Zen Buddhist in the same household, which was interesting. It was very interesting. My mother did force us to meditate from a very young age. Like, I remember her making us sit for 45 minutes when I was probably, under 10, for sure, because I can still see my brother squirming beside us, where we would just be like, sit still, or she's going to make us sit for longer if you keep moving. So there definitely has been a lot of my brain always asking, just questioning, not necessarily to rock the boat, but just being curious of if things aren't working in particular, if there's evident distress, or of thinking, like, how would we approach it without, because what I actually love about art is that it's a way of seeing differently. And it's a way of questioning, but it also offers a part of yourself you may not know exists, voice.
Sarah, I want to ask you about everything that you've been saying, because it's also interesting, but specifically what you just moved on to. I'm very interested in how, in particular, you see narrative or the health humanities as providing, I don't know if a solution, but an alternative path to the deficiencies in training and medical practice that you described earlier with regard to patients' bodies and practitioners' bodies too.
Yeah. So with the health humanities, what it offers is, again, a tool. I feel it's an underutilized tool in medicine. Part of that is related to the history of the way we understand knowledge needs to be delivered and the way technical information is gained as a skill. But that's a particular way that is actually heavily value-laden as to what is the most important and actually based on outdated data of what it actually means to learn. And, actually a nice parallel is in sport. So with sport, what they do for, like, let's say a free throw in basketball, they take thousands of shots so that their body calibrates to exactly where it needs to go. And it's a practice of arriving there, but it also requires trusting in the game. They need to actually turn off the control part of the brain to allow access to those perfect moments in order to do it consistently. And in medicine, we are trying to instill the perfection of particular skill sets, but we do it with a drive all the time. And interestingly, when you go with that drive all the time, it can build a particular kind of focus where you begin not be able to see the things around you because your senses are actually blocked. So neuroscience, because you go into control mode, which is actually rooted in fear, the fear of error. But when you are in fear of error or that fear mode, you actually have much more of a tunnel vision and you become less open to other information that's actually useful coming in through the senses. And this is, speaking a lot to the bias that we have that this is where the seat of knowledge is, when in fact a lot of things are being taken in and we've lost a lot of the ability to listen to this information and also receive it from patients. So we do try to teach what we call these observational skills. But sometimes, but a lot of what we are training in medicine is that we already know. And when you do that, you then actually block the reception of very useful information that can, actually lead you to think this is the way to solve the problem, when in fact you're just applying something that may not actually apply to this individual. So it no longer becomes about caring for the individual as they're arriving to you. And with what we practice in narratives is actually much more of this opening that part of the brain to receive information. And one example is when we take students to the art gallery, the close reading. It's the same skill you need when you want to look at an X-ray. It's the same skill you need when you want to actually look at a human body. Because otherwise, if you narrow, you miss like the gorilla that that there's that exercise where they have an X-ray and they literally put a gorilla and nobody sees it because they think they know and they're already decided and that part of their nervous system has closed down to receiving that information. And so there are a lot of, what seem like frilly activities, but are actually training skills that are necessary for us to be very well-rounded practitioners. But then on the other flip side is one that also can be very soul-nourishing because art can be playful. Narratives are playful. It allows that part of expression that is what the whole human being needs. And that we, part of it is it conflicts a bit with some of the values we have in medicine, in particular around stoicism. And then the other one that really comes to head is self-sacrifice. So, there's a stoicism, self-sacrifice, and loyalty are three that start to play against the practitioner when it comes time to how do we make space for these practices. Because they're seen as less necessary because we are seen as being less necessary to take care of ourselves.
Yeah, I'm so struck by what you're saying about how there's this sort of disembodiment that goes on in terms of the practice of medicine, and the work of healthcare is so much to deal with bodies, but there's a bit of a disconnection in the culture, in our training around our own bodies, in the ways that we might relate to the patients or clients as well. And I'm thinking about the issue of stoicism, which I haven't heard explained in that way, so I'm really intrigued if you could say more about how you see the impact of practice on the clinician or practitioner, and how arts and may be able to address that so that we're not working from that value, which can be quite limiting.
Yeah, it's actually a tough one because societally, we learn to ignore what is happening in our body from the moment we leave the womb. Children are shushed. They're told to sit still. In class, it's like, stop fidgeting. And so these are a lot of, ways that as a society, we still value this as being the seat of, knowledge of how we need to direct. And then what happens over time is that this becomes a place of control. But when you do that, you're not necessarily responding to the signals you're receiving. And so that does get exaggerated, for example, in medical training, because you're taught to plow through, even if you're hungry, tired, you have to go to the bathroom. Like, all these basic needs are pushed to the side, and you learn just to soldier through it, which is what, and a lot of that language exists for a reason. It's providing the metaphor of what happens is that you are becoming a soldier for the system. And there's lots of different kinds of work written on how it ties into way even back in the Neolithic times when we moved from hunter-gatherer to the Neolithic agriculture, because agriculture was the first time we tried to control our environment to ensure safety. And so it's a long, complicated path, but it really gets exaggerated. So we're picked, like, the typical candidate who arrives in medicine is usually a very giving person, obviously very academically inclined, but also we are typically avoidant personalities. So we deny that we have suffering. Like, we deny that exists. It's like, oh, I just tough through it. I'll go for a run and I'll blow it off. But and that can be useful, but it can also be an avoidance technique for emotion. So emotions in medicine are a place of shame. There's lots of stories. It's changing now. Lots of stories where people would, be told no tears allowed.
Emotion-free spaces.
A lot of shame-based feedback on emotion, when in many ways that's actually what our patients are seeking, is like, am I talking to a robot or am I talking to a human being? But the system is designed to train a robot, a deliverer of technical knowledge and information and skill. And so this is a fascinating time right now, because they're now looking at, CanMed's revising, like, what are these basic competencies and what else do we write in there as, like, what is our ideal of what we want to call a medical expert. And it is, it has changed quite a bit over time, where we are a technical specialty that holds a particular kind of information, but it's not the only one. And when you're trying to deliver person-based care, it means it's actually more of a collaborative exchange. There are certain scenarios where it's more cut and dry, but there's a lot of scenarios where we're doing a lot of social management as well, where you do need to actually be in relation with one another, but that's not what the historical training of medicine is. And I think that's a good part of my role, is to start to shape and integrate ways of allowing us to relate as people. And that's often what the most of the complaints are usually around: feeling dismissed, feeling like I'm not heard, feeling like I've been treated with contempt. So that's a common, actually, kind of emotion you find in the medical setting, is one of contempt, because of the history of where it comes from, because we are, a hierarchy of, we have this knowledge, and it's like, yes, but this knowledge is something that we are meeting people with. And we may think we know better, but at the same time, have we actually taken into account this entire person? And because a lot of the times when the person actually feels heard, you find less of that feeling of disagreement. Like you can actually arrive. And a lot of it is usually often misunderstanding as well, as of the person their model of the body and the model of the technical body are, you can find anything on the internet. And so that's also, it does, some colleagues say, well, how am I supposed to be able to do all this when I have such little time with the technical information? And that to me is actually more of a system design flaw. It's not an individual failure, it's actually a system failure. And I feel like part of my role is actually beginning to rethink, how do we design this system? Because there is a way. It's just that right now it seems elusive because we haven't really spent, I haven't had a huge amount of time, but there is a different way to do, create a person-centered model while navigating the current structures that exist.
How has your own creative practice, your work as a dancer, or your writing, your other creative and reflective activities contributed to your, I was going to say to your thinking, but to your practice in this field?
I would say that dance practice is really what alerted me to how disembodied we are in medicine. And part of it was noticing that I would do, for example, a shift at work, and then I would go into dance studio, and then I would wonder why it would take me so long to actually feel like I've arrived in my body. Mm-hmm. And then over the last, I would say decade, I suddenly realized, it's because when I'm in clinic, I'm completely shut down from here to here just to get the job done. And then thinking, and that started to make me think of, well, what are the reasons this is happening? What are the reasons that people feel like this is normal? And then also, why do they feel badly about wanting to address it? So a lot of the value-laden judgments around it. The other thing, when you spend a lot of time with artists, it's a different way. So it's two different ways of thinking, two different kinds of dominance of brain things as well. And that made me think a lot more about integration. Is how do we go, take this extreme and this, but there is always a way to integrate and arrive at a middle ground. And the different questions that come up and how things are phrased. And a lot of the curiosities that come through the narrative practices is the play of the language around it too. It's often they're talking about the same thing but using very different language. And so arriving at common language or exploring the language. Or the other thing that I think is really wonderful about narrative practices is that it allows people to also witness someone else or another person's story in a way that if it's just presented as a lecture, for example, it doesn't necessarily have the same impact because it carries that individual's voice, whether it's visual, whether it's literary, whether it's in a physical form.
It's also interesting to think about the dialogue between different forms. I've used the beautiful video that you co-created, the choreography of care, with clinicians and with learners as a jumping off point for some narrative, for some writing reflection, helping us think about day-to-day practice through the lens of our bodies and of movement, and what are the movements that we might make kind of mindlessly, to use that language, in the course of our day-to-day, and how can we bring more awareness to that, as well as the impact on our bodies. Mm-hmm. So it's been a really interesting creative tool. And I love that dialogue between the dance and the movement practice and narrative and writing and opening up dialogue between those.
Observing who was very uncomfortable watching it, and then those who were able to take in the emotion of it, I found really interesting. And a really great, as you say, point for discussion, like a springboard for discussion on how we manage bodies, because we're supposed to be experts on bodies in medicine, but we're not. Like we're experts of a particular kind of worldview of the body and model of how to organize things of when the body goes wrong. But we're actually quite far from understanding it as an integrated whole, because medicine's very reductionistic. It's disease-based. It's more systems separate from one another, and we have a much harder time thinking about that whole system integrated. And we're getting better, like over time. The profession is changing. The knowledge base will always continue to change. There'll be different kinds of models. But the other thing that's fascinating to observe in medicine is how much difficulty people have acknowledging that we may not have the answer, or that our answer might actually be wrong, which I actually think is a very important thing. I never tell my patient, I never say the words, oh, this is impossible to happen to you. I think anything is always possible in medicine, and anything that we are delivering at this time is our best guess. So, and patients don't necessarily like that answer because they want to know, but that's just the reality of the human body. And we are dynamic systems interacting with like a dynamically changing from many different factors.
It's also a very artistic approach to take. You're not going to think, I've written the final poem, we're done.
Yeah, it never quite ends. There's always, an evolution. But having the humility to accept that and not worry about that necessarily indicating failure. So that's actually the problem of medical education right now, is still heavily shame-based. And yes, you need people to perform really, really well, but you actually need to also have the learners be able to navigate and cope with failure, because it's inevitable in medicine. And I think that's actually what also makes it emotionally difficult when you arrive, is we pick the top of the classes. People are not, very few have actually experienced failure, but you're going to experience failure in medicine, which is emotionally devastating. So we need to equip them, equip the learners with this ability. And to me, actually, narrative practices are the perfect tool, because it's always with you, it's completely accessible, you can use any medium you want to at least start to have a conversation with yourself of what it is to enter into this fairly heavily emotional world. And that is another thing historically that has been a problem, is trying to deny the emotional body. You can't separate emotion from medicine. It's inherently emotional because it's relational. As soon as you sit in front of another human being, you have automatically entered into relation with that person. And you can't, you're denying that the emotions are there, but that's not the same as saying, I'm completely unbiased. It's that's impossible.
And you enter into those relational moments, as health humanities practitioners have pointed out, in a very charged moment, usually a moment of either critical illness, loss, chronic illness, pain. It makes me think, in terms of you're how as a medical educator, then to bring the arts and humanities to learners, to clinicians, is a really interesting process, because the arts and humanities do so often embrace uncertainty and ambiguity. You could say that that's actually kind of what they're about. And that could be actually quite challenging for some people. Mm-hmm. Very useful, enormously valuable, but also challenging.
Mm-hmm. Yeah, can you tell us, Sarah, just building on that, you've been hinting at it already, but what we can expect, what you have planned, or what you're thinking about in terms of your role at the faculty?
It's there's lots. It will be slow integration, because one thing about change is that you don't want it to be overly radical and destabilize everything. I do think there's simple ways to insert moments. Part of it is even thinking about how we design lectures. A very straightforward way of doing it is as you present a case, is just simply to put beside it a patient's representation of their disease. You do this lecture on the disease, and you've already, you don't have to even talk about it, but just by presenting that, because we are multi-sensory beings that absorb things through all of our senses, when you present something that's visual, like a piece of art that a patient has done to say, this is my experience of my disease process, and you just keep going in the lecture, you can talk about all the different technical components around that. You've already brought in a voice that people would not have otherwise considered. So I'm thinking small moments like that. There are larger things around looking again at the portfolio program that Dr. Ellen Peterkin developed, and seeing how we can enhance that even more, and also bring that to the postgraduate level to allow, again, a learning opportunity. Also just creating some space for people to reflect on what they're going through. Because medicine is an enculturation process. It's not simply, no technical specialty, doesn't matter what it is in the world, there's always some enculturation that happens of sort of the expected behaviors. It's a performance. It's the same thing as learning to be on stage. You are learning and to step into role as a doctor. And using, again, that metaphor of what do you do to prepare to be an exceptional performer here? But that also allows us then to separate the performer from the person. So when do you get to take off your hat, and what happens behind there, and what support do you need? Because this performance stage is incredibly intense. No matter what you're doing, you are dealing with life and death. Each decision you make as a physician, you are affecting someone's life directly. And, to me, they're always major. And so that burden of responsibility is a heavy one that no one can quite explain to you before you enter into the training program. And a lot of people have to, and get a lot of, and no wonder we're so anxious, is because people feel the weight of that. And so wanting to offer to students much more open dialogue around, it's really hard to train to become a doctor. It's really painful. It takes sacrifice. You lose your social life. The way the system is organized right now is not humane, or historically it's improving. But the system, unfortunately, that we are being trained to work within is also, we're lacking in resources. So there's a lot of these different factors which make it difficult to exist as a human being. But we can do it. It's not impossible. And that's, again, where we're, in my role, I'm trying to also talk about why story is important. A visual story, poem excerpt from a patient, it doesn't have to be complicated, but it is worthwhile to, again, put that into the curriculum. It's a way to start talking about the more difficult topics around equity, diversity, and inclusion, which in medicine is, a big area of focus that is necessary because of the hierarchy that has existed over the history of it, in a way that's actually been harmful. And it's, again, a way for us to acknowledge the harm that we have inflicted as a profession, but then to say, well, where do we go from here? And there are, I think it is changing again as a landscape. A lot more colleagues are beginning to understand and recognize what the role of the health humanities is. And they often talk about how it's, they call them soft skills, but these are not soft skills. These are core skills that are essential for you to be able to deliver care from a person to another person. And they're not inconvenient. They will help you in your personal life. And it just, these are just lifelong skills that we can actually fine tune in terms of being able to deliver it while developing a higher level of emotional intelligence that's needed in order to also prevent burnout. It ties into the burnout. So I'm sort of starting still a little bit on the periphery, but really trying to go in to the actual core of the curriculum to say just small adjustments here and there. We can measure it. Maybe we can do a lot of different kinds of research projects and measurements around it, which is another thing that I'm trying to organize within my role of these great research opportunities for learners and clinicians that are interested. And then, again, like nothing, I'm not going for dramatic. I'm just going for, let me present this. Can we try this? Again, it's a negotiation and just see. Like part of it is, again, to emphasize that our knowledge of how the human being learns and what is considered necessary as knowledge base now is different than what the historical model is supporting.
Sarah, it's been wonderful to speak to you. It's been wonderful to learn from you again, as ever. As a final question, we're just wondering, are you reading anything interesting these days related to health or just culturally interesting that you'd like to share with us?
Yeah, every Christmas my in-laws give me a book. And this year they gave me the novel Lady Tan's Circle of Women. And it's actually about a medical practice, like the traditional Chinese medical practice, like back several centuries ago. And it's also beautifully written. So it's a really rich in terms of imagery and textures and just beautiful writing. But it's fascinating also just to read about how they applied and how they would do assessments. So it's been a fun historical read, like historical kind of fiction read that I do recommend because it is pretty relevant in terms of these different kinds of valuings of systems. And it's very culturally rooted in a particular time, which is always nice to read from a distance.
Wonderful. Well, thank you very much again for joining us.